Juan, Greg, thanks for joining me today on the floor of TCT 2024, beautiful Washington, D.C.
Thank you for the invitation.
Thanks.
Good. Well, I want to start up, we're starting to have more and more conversations here at TCT and healthcare at large around clinical decision making, data-driven decision making, and you mentioned something before we started rolling about historically we've made decisions one way and we may look at it another way in the future. Expand on that one.
Yeah, look, I'm a data-driven person, and we met a couple of years ago, and I remember I told Greg, I said, Greg, I don't know if you realize that you're doing perhaps one of the most important things that need to happen right now in medtech, and is essentially basing decisions on data. And if I could say which is the biggest change that I have seen in the last couple of years on innovation, is about the use of data to make decisions. Clinical decisions, business decisions, innovation decisions. And I really think this is the biggest shift in our industry, moving from clinical need, solving a specific structural problem, into do we really need to develop something like this, and are we going to really make an impact on patients' quality of life, mortality, and so forth? And that's where data-driven health is the future of what we do.
And Greg, you're an interventional cardiologist as well.
It's a general cardiologist.
So general cardiologist.
Yeah.
It's okay, sorry.
Not just.
That's just what I mean.
Yeah.
But you have taken a keen interest in the pursuit of this data worldwide.
Yeah, so I'm a general cardiologist and echocardiographer at the Institute for Health Metrics and Evaluation in the University of Washington in Seattle in the US, and I direct the program in cardiovascular health metrics. We're all about measuring cardiovascular health around the world, and I also direct our private sector client services group, and there we're really working directly with the private sector. We're working with industry to try and bring that data to the decisions that they have to make every day. And so we work with almost every country around the world really to ask a couple questions. What data is there to guide us? We aggregate all of that together that's available in our data suites. And then using advanced statistical methods as well as clinical insights, we're trying to get the right information to the decision maker. And sometimes this is a health system leader, sometimes this is someone in the C-suite, but a lot of times around the world, this is someone sitting in a ministry of health who needs to understand, what are the problems I have to deal with? And what's the biggest problem, and what direction are they going? What trend is, and so we build forecasts into the future for mitral valve disease and calcific aortic valve disease and coronary disease and pulmonary arterial hypertension. Health systems are being built around the world, and here in the US we have health systems that have been around for a long time, but in a lot of other countries, it's early days, and they're really smart about this, and they're saying, we need more data to make the right decisions about, how do we build the hospital of the future and not make the same mistakes that got made 50 or 70 years ago? How do we make sure that we're building the 21st century version of a healthcare system and not some kind of legacy system that we're just copying?
Now you mentioned a word there that I want to explore, right? So changing centers of care. The provider, that's changing. We're starting to see in the US, ASCs are starting to become more and more driven. Cath labs are heading into ASCs, not any longer exclusively in a hospital. We're seeing even health at home, although on the surgical side. So I'm curious, are we going to reimagine not just what a hospital is, but where you might get a procedure?
What is interesting is, we talk about a standard of care, but we don't talk enough about a standardization of care. And the only way to really achieve a standardization of care, meaning that the diagnosis or the therapy is individualized to what the patient needs, is to really understand if we have data behind that. We're treating all the diseases kind of in a way as if they were uniform, and patients are not uniform. But with data, we can standardize the treatment according to age, risk factors, probability of success, and so forth. And this is where the power of data really comes and really help us to create standards of care by standardizing care, which is something that actually I don't think people realize.
And in the US and Europe, there's this question of should we be switching from a cath lab that's in the hospital to a cath lab that's in some kind of ambulatory space or surgical outpatient center. But across Africa, across Asia, our partners in these countries are not doing these procedures at all, and they know they need to start doing them. And so it's a little bit of a different conversation when you're not trying to move from one system to another, but you're actually starting from scratch and saying, we need to build the capacity to do these kinds of procedures, and we're not doing any of them now. And so they can start maybe a little bit of ahead of where we are by saying, what's the right way to do it here within the context of our system, within the needs of our patients, and what do we know about the disease patterns in our own country, in our own region, so we can really tailor these often expensive investments to make sure that people are getting sort of very sophisticated care that can sometimes be delivered at lower cost.
Well, so let's start with the US and then step out from there. Are the interests aligned in the healthcare system today for the gathering of statistics that should drive therapeutic decision making?
I think it started to happen. I mean, you see now institutions are more open to share data, which before was very difficult to do. There are already several companies that have been successful to extract millions of data points from big clinical centers. Before, people were very concerned about sharing data. I think now they started to see the need, and I think people have started to get aligned, even companies, but it's challenging. I mean, it's challenging to be able to get all the data you want. But I think we're getting there, don't you think?
Yeah, I mean, I think it's been, in the US, decades in the making, but there are a couple changes that have occurred in the last year or two with the regulatory framework for how data can be shared, especially when it's driven by a physician and their patient. I mean, I think that's where we all start as practicing cardiologists, to make sure that the data is being used to answer questions that are going to benefit our patient. So now in the EHR systems that most of us use, we can pull data from any interaction a patient has had in the system, in healthcare, and not just from our system, and not just regionally, but nationally, and not just hospital-based, but ambulatory or urgent care. That data is starting to come together. I think part of the problem is what it feels like to drink from a fire hose. And so I think what's really exciting about where we are now is not that we are at a time when we're starting to pull the data together. I think we're there. It's that we're starting to build the systems that help us manage the data, make use of the data. That's where you see things like AI really coming in. We have millions of ECGs that we've collected, but we're not drawing inferences from them. We're not using it to really make sure that we're identifying the right patients with that slightly prolonged PR, that slightly prolonged QRS, where we need to go back and think a little bit more about how to care for that patient. And so I think it's exciting, but I think that's where the real advances are going to come over the next couple of years, is how do we create the systems that help us make use of the data now that we finally unshackled it?
When you incorporate AI though, in early days, we're a lot more of what we don't know than what we do know, especially in AI. And AI now is going to make decisions. And we're introducing, for the very first time, into data, an agent that is going to make decisions. That's based around a less than optimal algorithm. So now we're treading on organic decision makers, now handing over that control to inorganic decision makers on the AI side of things. Can we go too fast with AI in this clinical decision making?
It depends. It depends what we're talking about, because there's so many shades of gray and so many conditions, diagnostic tools, therapeutic approaches, that it's difficult to say yes or no. But I can tell you one thing, for example, look at EKGs. All right, you mentioned EKGs. As simple as it is to read an EKG, you will find that there are differences in opinion in terms of what the interpretation of the EKG can be. The standardization that you can achieve with AI is something that a human cannot really do. You cannot count millimeters. You cannot really count a small variation of a wave. And I really think in regards to these tools, we cannot even get close to what AI can do. The same thing like reading echoes, standardizing the reading of echoes or imaging. So I think there are some conditions in which, to be perfectly honest, it doesn't scare me much. There are certain areas when you go into decision-making process in which now involve other type of intelligence, which is emotional intelligence, understanding the patient, understanding the family, making a decision based not just because what the numbers say, but what you really feel should be done. I don't really think we're there yet.
So you're feeling okay, and I would tend to agree, that the AI from the diagnostic perspective, but not the anything more than maybe advisement, is where we should stay right now.
Yeah, I mean, maybe it's happening somewhere, but I mean, in my practice, what I'm seeing, I don't think we've handed the reins over to AI in cardiology at all. But I think the diagnostic promise is huge. And I think that's one of the lovely things about cardiology. It's a very quantitative field, and so it really lends itself very well to using new software. And to be honest, we've been using a lot of software for a long time in cardiology. So in some ways, these, neural networks, large language models, whatever you want to describe, they're just doing a better job than the old software in some cases. We knew that we had to move from like the, visual assessment of a coronary stenosis and angiography to something more quantitative. We knew that 20 years ago. We just didn't have the technology to do it. So I think the diagnostic space is really promising. There's another space though, which is around unstructured data and the way that these AI tools can provide robust analyses in the absence of hypotheses. So that's an area where the science has moved very quickly, and it's not the known unknowns, right? It's the unknown unknowns, and I think we're leaving a lot of data on the table, and I think what these tools are going to help us do is improve the care of our patients with information that nobody's looking at right now. EKG is a great example. There's a huge amount of information that we get taught when we learn how to read an EKG, but there's more information in there than even that we get taught. Yeah. I'm an echocardiographer. There's more information in that echo than I can see with the naked eye.
You can see with your own eyes, yeah.
And so I think that's really exciting, and I think making use of information that we're collecting, but we don't know how to look at it. I think that's an area where we're going to move really quickly.
Yeah, I think it's very clear that's where AI has a competitive advantage with very little resistance from the inorganic agent making decisions on itself. So Greg, give me an example of the use of data in a, let's call it an emerging nation, whose healthcare system's still in its infancy, and we're going in there and we're going to help them build an infrastructure. So if you could, give us an example of where that would be.
The first thing I'll say is I helped lead something called the Global Burden of Disease Study, and the collaborative network that runs that study has over 12,000 participants. These are research scientists, physicians, Ministry of Health, and government officials, and we're really trying to bring data-driven evidence to public health and health system decision making. We have developed a method by which we can report not only what the levels of different kinds of cardiovascular disease are. We look at all diseases, not just cardiovascular, but around cardiovascular, we can also attribute it back to what the risk factors are that are driving these diseases, and they're things that oftentimes as physicians we're not looking at. So I'll give one example. Air pollution, small particulate matter, PM 2.5 it's called. This is a global problem. It's getting better in some places, but in some very low resource settings, that particulate matter is not coming from industries that you can regulate, but from indoor air pollution from cook stoves. And there's still millions and millions of people around the world who cook their food with fuel indoors that creates a huge amount of smoke that they then breathe every day. And that is a massive driver of cardiovascular disease, and we measure that. And we were able to give this evidence to colleagues who are part of our network in Rwanda, and they took that evidence to their colleagues in government, not just in the Ministry of Health, but in the Ministry of Finance, and they said, we need to invest in clean cook stoves. And they created a program where they were able to go in and bring low-cost, clean cook stoves to many, many people in Rwanda and very quickly, rapidly reduce the amount of indoor air pollution. So that's an example of where you take data, And that data was there. We didn't do new data collection. We made it useful by transforming it. We did it in partnership with the folks in that country who told us what their problem was. And to be honest, it's not that they didn't already know that indoor air pollution was a problem for heart health. It's that they needed that evidence to change people's minds. And so a lot of it is about using data to tell the right story.
So Juan, you lead CRF and are a critical part of putting on TCT. And I'm continuing to watch the conversations that CRF and TCT are having at large with the cardiology market in general. Is that a specific agenda for CRF and TCT?
It's actually interesting because you're going to see it tomorrow at the opening. I got people coming to me and saying like, are you actually going into the AHA, ACC direction? Or are you actually even talking about prevention? And I have to tell you, I really think we have to change our mindset, all right? Because it's not just about putting a device in, but it's about the lifetime journey of the patient and prevention and data-driven health and making sure that when you put a valve in, that you do the right things so the patient stay home is perhaps as important as teaching the procedure itself. So the changes that you have seen are more about creating awareness of what we believe is truly important, that it's not just about the device, but it's about taking care of the patient as the patient and making sure the patient stays home and healthy, all right? So that's why we're having a lot of conversations about prevention in the setting of intervention, and that's why we're talking about also a lot about data and the impact of AI, because our ecosystem will change based on all these new developments.
Yeah, and there's a responsibility to our country and the healthcare at large, expenses, right, 18% of our GDP, and the only way for us to continue to control that is to cover the entire ecosystem,
Exactly right.
not just the episodic moment in care.
Exactly.
Yeah. Well, gentlemen, I appreciate your time today, I really do. The conversation on data outside of maybe the OR, but actually in cultures, countries, and beyond.
Thank you.
Thank you, gentlemen.
Yeah,
Thank you for the
Thank you
invitation.
very much.
I'm Joe Mullings from the floor of TCT 2024. Be well.